by involving the women in the design, in the layout of the programmes, the accessibility to the programmes and the evaluation. Now, policy translation and scaling, the findings from CBIG-SCREEN, they should inform national and EU-level strategies. Evidence-based interventions need to be adapted, implemented and scaled across diverse settings to reach all women. Research without policy translation leaves women unprotected. So the policy translation is really important. And nowadays, of course, we all have to be brilliant public speakers if we're going to get our message across, because we're fighting against so many other brilliant public speakers. But I have to say to you, you have the voice and you can add the likes of myself and Maria Walsh MEP and many other MEPs to your voice, and you can target other institutions and your national governments and so forth, and ensure that you get the best, the brightest and the biggest and the best speakers to ensure that this topic is put front and centre. And of course, in many of our national governments, we have a lack of representation, female representation. So it may be harder to get those females, but of course, it's just as important to get those male politicians. Male politicians, they generally have a wife, they generally have daughters, they generally have nieces. So and I know you are engaging them. Now, why this matters to us? Well, it's a call. This day, this event, which I'm really delighted to co-host with you, it's a call to collective responsibility. As an MEP, as a female MEP, as a mother of a daughter and a son, and as a wife to my husband, I really do personally feel the weight of this responsibility. It's so important to ensure that our females in society, that they are protected and that their health and life is guaranteed for themselves, for their partners, for their children, for their families, and also for what we give to society. And we do give a lot. Now, this is not a burden, of course, that I bear alone. It's a shared duty, and each of us here today, I know that we actively take on our role to listen and to learn and to advocate and then to act. Just do it. The old Nike slogan is probably as old as myself, but it's still relevant today. Just do it. Sometimes we overthink, sometimes we overanalyze, and sometimes we just have to do it, whether it's picking up the phone, running to talk to somebody that you see on the corridor, engaging with somebody else that may be of, use to you in this very important piece of work, but just do it. So I urge you to embrace the lessons of the CBIG-SCREEN project and the broader evidence base. And that is, of course, to ensure that screening is totally inclusive, leaving no woman or women behind. It's also to invest in capacity and infrastructure, ensuring that screening programmes work efficiently and effectively with oversight, robust oversight for all, and to create transparent and accountable systems so that women know that they are supported and protected. So equity in health, it's simply not an option. It's the foundation of our European values, and it's a measure of who we are as a society. For goodness sake, if we can't look after half of the population or whatever amount we represent, half or a little bit under, a little bit over, well then what kind of a society are we, really? And the same goes for our young people and our older people, the two most vulnerable of our society in general terms. But women are definitely a close third on that group of young and old. Women, of course, their access to prevention is always determined by women's circumstances. And if we don't look at those circumstances, we fail, not only for the individual, but for the collective, the family, the community, the society. I'm coming to my closing reflection. CBIG-SCREEN has shown us the path forward. And I thank you for that from the bottom of my heart. And it reminds us, this project, that solutions are possible. Possible when? When we listen, when we involve communities, when we hear it from the ground up, and when we design systems based on the intelligence from the ground up, systems that are accessible and that are reliable and understandable. So it demonstrates also that prevention, it's not just a technical endeavour on a piece of paper in a thesis or in a government department or in a European Commission DG folder, but it's a moral one. So today, I know I'm calling upon you to do lots of things, but I'll call upon you once again, policymakers and researchers and civil society, and of course, healthcare professionals. Take this evidence and please, please translate it into action. And let's be guided by our spirit, by our hope, by our shared values, by our energy and our commitment to act. And act every day of the week, every week of the year. We'll keep going. And when we get a bit tired, we'll reach out to our wonderful friends in this great coalition and we'll say, I need a day off. Could you stand in for me today? Could you raise your voice? Mine is a bit tired. Could you take over? So let's do that and let's envisage a Europe where cervical cancer is no longer a life-threatening inequality, that it is today, still. Imagine that in 2025. Can we believe it? I can't believe it for my daughter, who is 25. So can we envision that Europe where it's no longer life-threatening and where prevention reaches every woman and where no voice is left unheard? The work of CBIG-SCREEN, it's really a reminder that progress is possible where we bring all your talents together and all your wonderful work and you engage with the community. So cap diem, let's seize the moment, okay? Let's act. It's not tomorrow, it's not in the abstract, it's the here and now. And of course, it's the reaching out at every opportunity. And with your help, and amongst all of yourselves, and I'm sure you're going to go further beyond Europe. I can see this project going beyond. I'm sure it has gone beyond Europe as we speak. But let's work widely and richly and energetically to build a more equitable and just and healthy Europe for all of our women. I thank you from the bottom of my heart. O one Mhurchú, as we say in Ireland, from the bottom of my heart. O one Mhurchú, I would like to thank you all, and I would like to wish you the very best of luck. And I would like to say, Beramish Bua Lechele, which is what is my signature little motto on my letters, and it means, let's succeed together. Thank you.
Next slide, please. Now we're coming to our panel discussion. You see our brilliant speakers up here. They're all working in the CBIG-SCREEN project and have done a number of fascinating and interesting aspects and tasks in the project. And we're very happy and delighted that you're all presenting here your work. I will just briefly make a short introduction to each of the panelists, and then I will give the mic or the floor back to the whole panel. Next slide, please. So we have Mark, who will also briefly talk, or will be talking about how to reach also underserved groups, because that was one of the core aspects also of CBIG-SCREEN. To our very right or left, as you will see later on, when the cameras jumps back to the panel, is Pia Kierkegaard and Pernille Mikkelsen. Pia is working at the University Research Clinic for Cancer Screening in Denmark. She's an associate professor at Aarhus University, a senior researcher at the just previously named University Research Clinic for Cancer Screening, also called UNICA. She conceptualized the CUP format that were just mentioned also before, the collaborative user boards for CBIG-SCREEN. You're actively involved in advancing the use of the CUPs in several other EU countries and through several EU projects, just as the already mentioned HB Faster Implement and also Brace You. Then Pernille Mikkelsen holds a master degree in public health and is a research assistant at UNICA. She contributed to the qualitative evaluation of the CUPs used in the CBIG-SCREEN, helped to support the future implementation of the method in prevention, design and tailoring cervical cancer screening programs, which is very much needed also as what also the panel is about. Then next speaker afterwards will be Rachel Greenlee, who will be talking about scoping reviews of marginalized communities in vulnerable positions. Rachel is a fellow, research fellow at the London School of Hygiene and Tropical Medicine, working across the departments of epidemiology and population health and public health and policy. Within CBIG-SCREEN, you led the scoping review and coordinated participatory action research to help give voice to women in vulnerable positions in selecting the project's interventions. Then we will be coming to Lise Rocher, who was already on the screen several times. You will be presenting also about the decision-making tree for designing, planning, tailoring cervical cancer screening programs. Lisa is a professor at economics at the Paris School of Economics and leads the project's work on inequalities and structural barriers to screening access. You bring a wealth of expertise in public policy and also in health economics. Then Isabel Mosquera-Metcalfe we'll be talking about several cancer screening and strategies. Isabel is a scientist at the International Agency for Research on Cancer, IARC, in Lyon, and coordinates work package 6 in the CBIG-SCREEN project. Your work focuses on the strengthening of cancer screening programs with a particular emphasis on improving equitable access to cancer screening among underserved populations. And then, last but not least, we have our online speaker, Rosa Leagood. Rosa is an associate professor of health economics, also at the London School of Hygiene and Tropical Medicine, and leads the CBIG-SCREEN work on cost effectiveness and economic evaluation. We're also talking about the cost effectiveness of CBIG-SCREEN and tailoring interventions. She has extensive experience in supporting evidence-based decision-making in public health and cancer screening. And we're delighted to have such a fantastic panel here today with such a wealth of expertise. And I give the floor to you and would like to ask Mark to first talk about the Reaching Underserved groups. Next slide, please.
So that's this is a key question, because in fact, we submitted the project 3 times before getting funding. And the first time, the answer was, okay, you have clearly identified the population which has the highest need to reach out, but you did not give us enough information on the likelihood that you will really be able to reach those women. So in fact, there are 2 issues when you want to build tailored screening or tailored prevention strategy. First, to identify the population who are at risk, and the second is to be able to reach out to these women or to these people, because they may not be only women. The idea is to go where they are, to find a way to deliver things which have been considered as being effective, like HPV cell sampling, for example. But if you want to do that, you need to explain prevention, you need to explain how to use the device, you need to explain how to deal with the results. So that means that you cannot just send out something. You need to increase health literacy, you need to increase delivery mode, you need to increase data collection, you need to increase the downstream management. So that means that reaching vulnerable groups is really a way to something that we need a full chain. Also, I already mentioned that there is no one size fits all. So that means that intervention may depend on the different group you may be trying to reach out. And that's why Liz will be speaking about. We've been working on very smart way to understand the preferences. Admit that you can offer different way of being screened and say, okay, which one is you prefer, to truly understand what are the preferences, because sometimes it's unintuitive. We have been running a clinical trial in the island of Réunion, in French overseas department, where a lot of people speak Creoles. And we have asked them, do you want to have information being delivered in Creole? And the answer was no, because it sounds less official. And we need to have something that we perceive official. So that means that this is just an example to say that you cannot decide what is going to be done, understood, without working with the people, because sometimes you have different feeling when you're a health provider, when you're a researcher, when you're a politician.
Yeah.
So I don't have any magic clue to say, okay, we have found the only and the best way to reach 100% of the women who need to be screened. But I think that what we have done is identifying vulnerable groups. We have been working with these different groups, working with health literacy on capturing the system. And something that was mentioned by Cynthia, which is essential, is to be able to monitor the policy. So if you implement something, you need to be able to monitor that. Do you reach the target audience? If you're putting effort, are these efforts being maintained over time? Because you can have something like a blast and okay, you manage to reach and to screen people, but then you lose the effect. So there is no single way to reach the different subgroup of women. Sometimes the difficulty is to identify this population. For example, obese women are at increased risk for cervical cancer, but you don't have registry for obese women. It's not written on your ID card that you're obese. So that means that if you want, and sometimes you need to be very smart to be able to reach every of the group which have been identified as being at risk. Transgender men are also at risk, and also it's very difficult. Sometimes when you ask the politician, do you know how many female sex workers, do you know how many transgender men are in your country? Most of the time we don't have the numbers. So that means that we can only deliver intervention if we know who are the people who are at risk, where they are, how they live, and what is their knowledge of the prevention system. So that is what we are working on and for the HPV Fast Implement Program, we has a very specific work on health literacy. And health literacy is not only for the woman, it's also for the professional, because sometimes they don't know. And we have been conducting the capacity visits. Isabel will speak about that, and knowing that many physicians don't really endorse HPV self-sampling. Just, okay, I'm not sure it works. So that means that we need to work on both sides of the delivery chain, the physician and the end users. Yeah. That's it.
Fascinating.
Thank you very much, Mark. And for our online audience, if you have any questions in between, just post them in the chat and we will pick them up later on after the panel discussion. Next, I would like to welcome Pierre and Pernille, and for talking about the CUPs and the benefits in designing, implementing, tailoring cervical cancer screening programs, and probably beyond cervical cancer screening programs, just the use of reaching different groups.
Thank you very much. And thank you very much for the invitation to come and talk about the collaborative user boards. We call them CUPs, which we've developed for CBIG-SCREEN projects 6 years ago, and which are now being used widely across Europe. The question was, how can we co-create? How can we co-create the offer of cervical cancer screening with the vulnerable groups and for the vulnerable groups? How can we bridge the lived experience and the clinical realities with health policies to make sure that no one is left behind in the fight against cancer? Next slide, please. CUPs are structured spaces where policymakers, the macro level, healthcare providers, the meso level, and underserved people from the target group, we call them a micro level, they come together to identify barriers and co-create solutions. A CUP has three core functions, as seen on the slide. It acts as an advisory board to identify barriers and recommended solutions. It serves as a learning environment to foster mutual understanding and collaboration. And then it operates also as a focus group, and that is in order to collect qualitative insights for tailored interventions. They are to be consulted for troubleshooting during implementation and secure mutual learning, new collaborations that arise during the COP meetings. They'll ensure outreach and ultimately policy impact. And the goal is to design intervention that reflect lived realities. COPs are facilitated by meetings by invitation. All 3 levels count as stakeholders, also the women in vulnerable positions. This is important. Recruitment is deeply context specific, and each country has different healthcare structures, cultural norms, and vulnerable population. And recruitment strategies need to be adapted to fit these national realities, often using purposive and snowball sampling. Each COP meeting lasts about 2 hours and follows a structured interview guide. They take place face-to-face with 6 to 10 participants and sometimes also as hybrid. Facilitators are trained to be attentive to power imbalances. This is also very important. And to ensure that all voices are heard, especially those of the vulnerable women, by using culturally sensitive language and participatory techniques that help create a space of equality and alignment. And through the COPs in CBIG-SCREEN, we engaged 120 stakeholders across 7 countries. And here's what happened. Next slide, please.
Thank you, Pia. Bringing all 3 levels in the same room proved difficult. Is my mic on?
Yes.
Yeah, okay. Yes, and in most countries, the COPs were divided into micro-meso level together and meso-macro level together. The role of the facilitators were in this way to deliver the voices from one COP with micro and meso to the other COP with meso and macro level. Building trust and safety was crucial, and this meant preparing participants through pre-meetings involving familiar healthcare professionals or social workers, and using culturally sensitive language and clear information about role and expectations for all levels of stakeholders. Recruitment involved overcoming language differences, low literacy and geographic isolation in rural areas, and hesitancy among macro-level participants to engage with the target group. Next slide, please. The COPs revealed that at the individual level, women faced shame, fear, and low health literacy. Prevention is often not a priority when survival dominates daily life. At the provider level, paternalistic attitudes and lack of cultural competence discourage participation, and both micro and meso level call for better training in culturally appropriate communication. At the system level, missing registries, fragmented programs, and insufficient funding, especially in Bulgaria and Romania, were the main barriers. These findings show why participatory approaches like COPs are essential. They address barriers at all levels. They do not just identify problems, they create a space where those most affected can shape the solutions. COPs in CBIG-SCREEN revealed practical solutions that can transform access to cervical cancer screening. First of all, outreach and proximity work is essential. Mobile screening units, health mediators, and community-based initiatives bring services closer to women who cannot attend clinics. Second, tailored communication matters. Women need multilingual materials, culturally sensitive messaging, and peer-to-peer learning in trusted spaces. Local champions working with empowerment play a key role in building trust and encouraging participation. And health providers also need tools to communicate with women in vulnerable situations who need specific care and access to be able to attend screening. And finally, system-level changes are non-negotiable. Free screening for all women, integrated health and social services, and screening registries were repeatedly emphasized. Bulgaria and Romania call for fully funded population-based programs and a culture of prevention. Innovation must be paired with trust. HPV self-sampling was seen as empowering by many women, but others feared misuse or doubted test validity. Technology alone is not enough. Education and trust building must accompany it. In this way, COPs are a leverage point for generating policy-relevant insights grounded in reality. They ensure that change is supported by policies and connected to everyday life. CUPs have already influenced communication strategies in Estonia, inspired outreach programs in France, and informed cervical cancer screening policies in Italy. They bridge the gap between grassroots realities and high-level policies, aligning with the EU mission's call for equity and inclusion. If we want Europe's Beating Cancer Plan to succeed, we must embed participatory governance into cancer prevention strategies. Empowering voices is not optional. It is the key to equity and impact. The message is clear. When we listen to those most affected, we have the potential to design better policies, build trust, and create sustainable change. The work continues to scale these models across Europe and ensure that no human is left behind in the fight against cancer. Thank you.
Thank you very much, Pia and Pernille, for the insight into the CUPs and how to use them, and also the challenges that you faced there.
I just want to compliment both ladies. I've complimented Mark already, and indeed our other friends, but I just want to say that was really incisive, and a thought that was running through my head, and maybe the people watching online, this might be of interest to them, but CUPs, collaborative user boards, it's very much driven by the face-to-face, okay? And so yesterday I attended a lot on AI and the tech, and whilst the tech is going to be a wonderful welcome contribution, we can never lose sight of the fact that in this with this particular issue, we have to keep the human contact alive and well, and let's harness AI to assist with the CUPs, but it can never replace or come anywhere near that, in my humble opinion. But I also want to say to you, Pernille, that you're a credit to your to yourself and to your education, and for somebody so young to come and present, I just want to compliment you in particular. Thank you. Thank you.
Thank you very much. I would like to go on to our next speaker, Rachel, who will be talking about scoping reviews of marginalized communities. Rachel, the floor is yours.
Thank you, Heidi. And thank you very much for the invitation and the chance to speak here on behalf of Work Package 3. Also want to just mention that this is on behalf of the individual who had led the work package, Professor Martin McKee, who wasn't able to join us today, but of course sends his regards. So cervical cancer is one of the rare areas in public health where elimination is genuinely within reach. You've heard this before. You'll hear this many times again across this conversation today. Yet across Europe, the women who need prevention most are still the least likely to receive it. And this isn't because we lack evidence or technology, but because the way our systems are designed makes access unequal. And so CBIG-SCREEN started from a simple but quite an uncomfortable question. How do we redesign cervical cancer prevention so it genuinely reaches the most at risk in real lives, in real health systems? And Work Package 3 was the beginning of the answer to this question. So this is what Work Package 3 has set out to do. Our goal was to improve access to cervical cancer screening for vulnerable women, determining measures that are evidence-informed, acceptable, and feasible to implement. So we worked through the collaborative user boards that my colleagues have just mentioned, and really benefited from the time and the foundation that they built in working with vulnerable women to then be able to reach out further to Work Package 3 to bring together healthcare professionals and policymakers as well. And in addition to this, we use participatory methods to co-create strategies rather than just designing interventions for women from a distance, which is done traditionally. So across this work package, we did a few things. So I'll speak about the scoping review that we did, but also we mapped the full screening pathway in Estonia, Romania, and Portugal. And this was from identifying at-risk populations through to diagnosis and treatment. And why we did this was to examine where those pathways helped or hindered vulnerable women, because there's both. And why would we repeat the wheel? From there, we synthesized the evidence, and this is where our scoping review came in. And we looked at barriers, facilitators, and intervention for underserved groups in Europe. And this was structured around the macro system, meso, and micro levels. But this wasn't enough. We also needed to co-create, and this was really the ethos of Work Package 3. And helping to identify strategies to improve access. We spoke with women, providers, and policymakers that directly fed into the design of the interventions, which will be spoken about a little later. And so work package 3, I think, sits at the heart of CBIG-SCREEN. It's where lived experience, health services, research, and policy analysis really were pulled together into more concrete and testable solutions. So we saw the evolution of the project starting to really speak to and reach out to women where they were, where they are, where they live, and where they need the most support. So this is what we learned across countries. From the scoping review and our qualitative work, a very consistent picture emerged. At the macro level, we saw registration and insurance rules, fragmented governance, and unstable funding create structural exclusions. At the meso level, screening services are often organized around the convenience of the system. So complex booking, limited outreach, impersonal communication, everything that you've already heard and probably will continue to hear. But this doesn't reflect the realities of women's lives. And so at the micro level, what the picture that emerged was women face low awareness. There's a lot of stigma, fear of cancer, and the simple fact when you're juggling insecure work or care responsibilities or migration stress, prevention typically drops to the bottom of the list. So as one Romanian participant had explained during our Think Aloud work, which I'll explain a little bit later, I'm not avoiding screening, I'm just trying to survive my life. Let's paraphrase a little bit, but this was the essence of what had come out. And so just in quick summary of the 3 main strands of co-creation, the participatory work that we did in Work Package 3, we began in Romania with a Think Aloud process with underserved women. And this is where a lot of women took part and described their experience being uninsured, unemployed, or living in remote areas, that a lot of them spoke about fear of cancer, shame around gynecological exams, confusing referral pathways. But in the Think Aloud process, we introduced HPV self-sampling kits, and initially many were very anxious, but with clear instruction and supportive guidance, we saw in real time that their confidence grew. Women valued the privacy, convenience, and autonomy of self-sampling and could see often for the first time that screening is something that they might actually be able to do. So this is one example of some of the work that our incredible colleagues in Romania had provided to Work Package 3. Now in Estonia, we focused a little bit differently. Our prioritization was with policymakers, clinicians, and women, but through structured exercises. And so this was to help identify the most promising interventions. They already have a clear established electronic health system that has been working quite well. And so learning what interventions could possibly interact or engage women better through these pre-existing mechanisms were quite clear to us. And so this looked like clear communication of results, better follow-up reminders, and expanded access to home-based self-sampling. Now, we did some work with Bulgaria, actually. And so this was where digital storytelling really told the stories of 12 women, and this is where we went a bit deeper. And so through this initiative, we co-created 6 short but powerful videos around the experiences of cervical cancer prevention. So this was combining their voices with images and music. And these stories have been shared on the HPRC Facebook page, presented at different international conferences, and now form a lasting platform for advocacy and dialogue. And so across these 3 countries, a clear message emerged. Trust is the foundation, and we've heard this. And so women are more likely to attend screening if someone they trust supports them, if information is in their own language, and if the encounter feels respectful rather than judgmental. Now, I would love to dive a little bit further into Bulgaria as an example of a health reform monitor paper that we have coming out in the next month or 2 that will be published in the Health Policy Journal. I don't know that we have too much time for that. So what I might do
next time we'll extend the meeting.
Exactly.
Yes.
What I might do is just
There's great work going on.
Amazing. Describe a little bit about the difference that Work Package has made for the Work Package 3, sorry, that has made for the project. And so the impact of Work Package 3 has become, more and more to be seen as visible. So the evidence that directly informed the interventions, which will be discussed a little bit later, drew from the scoping review, our participatory engagement, and some of the previous work, the collaborative user boards, as well as country capacity assessment. So really the consortium did an incredible job of working together in co-creating our methodology in addition to then co-creating our evidence. Yeah. And Secondly, we, Work Package 3, continued to strengthen the stakeholder engagement that was really beautifully built by the collaborative user boards, increasing health literacy, increasing confidence, and increasing understanding of where women can build their voices through research and through not just standing idly by. And thirdly, Work Package 3 generated transferable and equity-focused evidence. And so again, we've got our scoping review that's been published. We've got a few health reform monitor papers, as well as working closely with our other colleagues through some of our publications that you can find online. But I guess I'll just finish with one core message from Work Package 3 is that vulnerable women aren't hard to reach, but they're easy to overlook. And so I'm hoping that through our work in co-designing services with underserved women, through listening to their fears, their constraints, their ideas, we can get different interventions and hopefully see different solutions. So that's a little bit more about what Work Package 3 has tried to achieve.
Well done, Rachel.
Thank you.
I just want to compliment Rachel first, if that's okay. It's amazing. You're probably cut short on your notes. I could see you had plenty cut short by me. I'm sorry I talk so much at the top because I know time is running away with us. But amazing and very kind of you to reference Professor Martin McKee. And he can't be here today. And those words will haunt me. They're not hard to reach, these vulnerable women, but they're easily overlooked. Thank you for all your work. Sorry, Heidi, you're chairing, not me.
No, that's fantastic. No need to be sorry at all. Thank you very much, Rachel, also for these insights. And I agree totally with you, Cynthia. They're easy to overlook, and that's important to look what do we neglect and what is neglected so far. And I would like to go on now to Isabel. No, to Lisa. I would like to go on to Lisa about the decision-making tree that was developed in the project. So what do we have to look out for now when designing, implementing interventions, when tailoring interventions or targeting interventions? And how could it be done? So Lisa, the floor is yours.
Next slide, please. Right. So I'm very thankful to be here today because it's really also very dear to my heart, women's health. And I'm very happy to have shared and led this work package together with PM because work package 4 was actually multidisciplinary with inputs from different disciplines, including, as you will see next, philosophy and economics, of course. So we've been putting together all the work that's been presented into a decision tree because we wanted to have something that would be ready to use for policymakers and making sure that the normative and social justice foundations would become the guiding principle in the design of the trees. So we had a lot of information from previous research within the consortium about barriers. We also collected in our work package evidence on women's preferences, but regarding the modalities of screening that they preferred. So much had already been done about barriers. We felt that we would move to understanding what would be the most important modalities that would increase uptake. And clearly, what we used is experimental economics methods where we manage to get women's preferences in this case. But what has not been done before, and which turned out to be quite a task and a hurdle, but in the end, a proof of concept, is that it is possible to use these quite elaborate methods to reveal preferences to vulnerable women who are usually indeed outside the studies. You may find in the papers that the discrete choice experiment has presented preferences, but unfortunately it was not possible to reach vulnerable women. So we started from there by saying we are going to reach out to these women to establish what their preferences are regarding modalities. So that's the work that Violette, the lead, has done within the project for her PhD. And this really is possibly one of the most important contributions is showing that experimental economics can be used to elicit women's preferences in order to design modalities. So in the decision tree, what we tried to identify were the most important normative foundations of EU policy. And clearly the most important is definitely the notion of, developed by Mahmoud, of proportionate universalism, which is to say that, of course, we want to give access to screening to all women, but we also understand that some women may have a harder time accessing, and therefore we need to have a special effort which is proportionate to their need. So proportionate universalism is definitely the grounding principle of most EU and possibly other European, beyond Europe, other sort of countries. The other important issue was to identify what we felt as researchers, a good guiding principle in terms of social justice. And clearly, the notion of equality of opportunity, which has been developed by Romer, is increasingly important in identifying what is considered as unfair because linked to circumstances where you live, what is your socioeconomic background, what is your health literacy, and what is possibly acceptable. So deciding on these, on this issue of what is fair or unfair is definitely sort of following the notion of equality of opportunity, which is a very interesting sort of way of summarizing these two main sort of elements in the decision tree, maybe in the next slide. The next one being the autonomy that is going to be given, obviously, to women. Next slide. So moving to the tree, this is not legible, but you have it. Fortunately, thanks to all the work by Heidi, it's in the sort of deliverable 7.3. You can read it for those of you who've got it under your eyes. But we can go to the next slide where I try to define the different steps. So remember, this is really a way of summarizing all the steps that decision makers will have, or policymakers rather, will have to take in deciding how to implement a targeted intervention in complement to universal access, which will be answering the needs of those who are not currently accessing screening. So the first, first step is whether or not there is indeed a sort of an existing organized screening. If so, you can next move to designing the targeted intervention that will be in addition to the step. And here, basically what we have to identify is those groups that will be in need, which we will call priority groups, which doesn't mean the others don't get access to free screening. It's just that we complement the action by having sort of special groups with special needs to whom we will be targeting the additional intervention. So that's the next step, identifying these groups according to the principles that we just mentioned of equality of opportunity, and making sure that they're indeed going to be clearly identified. The next slide and the next step to make sure we stay in time is actually really the important part of tailoring. So we've targeted the groups and we are tailoring the modalities and really making sure that these two steps go together. So we need to make sure that the modalities that we choose will be in agreement with the preferences which the discrete choice experiment that I mentioned before has helped identify, and together with the evidence, the qualitative evidence that's been generated by Pierre in work package 4 on reaching out women, understanding their preferences, and all this qualitative work together with the quantitative work of disease has helped identify the modalities that would be most suited to these women. And here we obviously, when designing an intervention, need to know what we can afford, because obviously we have to make sure that the means are in line with the ends, but we also need to ensure that we can reach those women that we, in effect, try to sort of insert into this priority group. And this is where the outreach strategy that's been mentioned before comes in, because in most cases, these women don't even access the healthcare system, and therefore there's no way to access them, to get to them. So here is where outreach, this idea that the healthcare system moves out to women in whatever way, is clearly an important part. And then in the next slide, we come to maybe the most important part to us, which is what are the different modalities that have been identified. And it's all in a circle, because basically you can either sort of just improve health literacy and stop there, which is the first segment, or you decide to go further and beyond improving health literacy and therefore women autonomy about making a meaningful choice. Well, then you move on to the next part, which is inviting them and sending them reminders, but all this in accordance with their preferences as expressed in the studies that we carried out. The next step, which reinforces, I would say, the strength of the intervention, is really to actually move to offering, for example, as we do in CBIG-SCREEN, we're offering sampling kits, individual sampling kits, and really identify the needs of women to be possibly accompanied into self-sampling. That's the third step. And in a very small number of cases, we actually also invite women to take a bonus or a financial incentive if they've actually returned the kit. This is the typology that we've identified. In CBIG-SCREEN, we do not go as far as using financial incentives, but Mark has designed another study where this is actually implemented. And so the typology really identified these 4 modalities as potential modalities for any sort of a strategy of targeting screening interventions. And the reason being, but Mark will speak about it better than me, the reason being that often giving financial incentives to women is seen as possibly this sort of controversial. So we can speak about it again. And the last final slide is simply to move to implementation issues. And it actually comes back to what Mark mentioned about making sure that the training is for health professionals, not just women. Health education and literacy is not just for women in this case, but also for healthcare professionals. It is also making sure that all stakeholders are willing to participate into the targeted intervention, so they all understand, the value of it. And finally, making sure that the follow-up is being clearly sent to women so that they know the result, which may seem obvious, but actually not always done. And so that's it for us. But thank you.
Thanks, Heidi. As we co-chair now, I just want to say
Yes, we can hear you perfectly. Rosa will be talking also about the cost effectiveness, which is also very good to hear and very good news that Rosa has to share with us about the cost effectiveness of these designs, especially when it comes to prevention. Rosa, the floor is yours.
Thanks. Can I have my slide? Thanks. So we started by looking at the literature about cost effectiveness of interventions to increase cervical cancer screening. And we've looked at both in the general population for women that were underscreened and also for women that were vulnerable women. And what we found was that there was quite a lot of information for Europe about underscreened women in the general population, and that if women have been underscreened, it would be a very cost-effective thing to do the screening, to screen them if they'd not been screened previously or they had a very limited screening history. But what we found was there was really no data available looking at people like HIV positive women or sex workers or migrants, targeting interventions at those types of women to look at the cost effectiveness of doing so. So as part of the CBIG screening project, we looked at the 3 countries, Estonia, Romania and Portugal, and thought about the interventions that had been implemented that Isabel has just been speaking about, and thinking about the impact, the cost effectiveness of increasing HPV screening in those vulnerable populations. So in order to do the cost effectiveness analysis, we had to build a cost effectiveness model. And first of all, we thought about the natural history of the disease. So that's the underlying characteristics of the disease. So a woman would get an HPV infection, and this would develop on to pre-cancer and cancer. And the vulnerable women might have slightly different rates of HPV infection. For example, HIV positive women have twice the rates of HPV infection as general population. So we adjusted the models, we set up the models of the natural history to reflect the populations that we were looking at, and then thought about the interaction between the screening and treatment. So when a woman is screened for cervical cancer, you can treat a precancerous lesion and then she's safe. And then we looked at the costs of screening and treatment and the different interventions and the quality of life and of the impact of having cervical cancer on quality of life. And all of these modules come together to give us the cost effectiveness results. And we're just generating the cost effectiveness results for the project. And what we found is that in Estonia, where they've moved from having an opt-in screening program to opt-out screening program, where they're self-sampling everybody, and that's got an increase in the uptake. And what we found was, although that costs a little bit more to implement the program, because you get savings in treating cancers because you prevent more cancers, you get cost savings overall, and you also get a gain in life years saved. So it's both cost saving and a gain in life years saved. So it's really positive news for cost effectiveness of screening in that context. That's my presentation.
Rosa, thank you so much. Gurmil Magat, so sorry that you had to wait for so long. But it was a really important presentation because, as we know, that everything, unfortunately, in governmental policy decision makings comes down to a budget. In Ireland, we know more about budgets than most because, like every country, we've been affected by the swings and roundabouts of the global economy and so forth. And just we've had some earth-shattering news that our finance minister has resigned overnight, and he presented 8 consecutive budgets in a row. And look, budgets are really important, and this is a really important message to get across to our policymakers and decision makers, our ministers for finance, and indeed here in Europe as well. So thank you very much, Rosa, for being with us.
Thank you.
Also from my side, thank you very much, Rosa, and thank you very much to all the panelists who have talked today, and thank you also to you, Cynthia. I know we only have very little time left, but if there is any urgent question in the room or online.
We're just checking now to see if any questions came in online.
The only question that was submitted during the registration was the inclusion of transgender individuals.
Very much.
Yes, in the upcoming project, or actually the project that we are already engaging in, also instigated by Professor Mark Badu, it's called HPV Faster Implement. And in Denmark, we are reaching out to transgender people and people who are non-binary with the cervix. in order to make sure that they are also given the offer of HPV vaccination and cervical cancer screening. But Mark, could you tell more about the project itself?
Well, there is not that much more to say. That in fact the fact that we indeed recognize that there is an issue with transgender men, we may not be perceived as being in need or may have difficulty interact with may have difficulties to interact with the healthcare system. So definitely that's why we have included this population and we want to work with them in the HPV Faster program to increase the protection against cervical cancer.
Yes, Rachel.
Thank you. And just to say, from our scoping review, we also found that there was an incredible lack of evidence around specific barriers, facilitators, and interventions for transgendered individuals, and which also doesn't speak to vulnerability being at the intersection and not necessarily just one type of vulnerability, that it can be multitudes as well. So I'm excited to hear the next study and findings.
Well, thank you very much. Please, Lisa.
Hi, could I still ask a question? Thank you so much for this panel. It was incredibly insightful. It's great to hear you present this research. I work for the European Sex Workers' Rights Alliance, and I think it's great that I'm hearing a lot of interacting with leaders of vulnerable groups, or talking about participatory project development and how crucial it is that all voices are heard, specifically involving vulnerable women as you described them. I just can't help but wonder, you're all researchers and medical professionals in this table, and of course an amazing MEP also present here. Where you've been talking about how this process is participatory, and you're really from the ground set of the project involving the groups that you're speaking with, so sex workers, but also trans people, incarcerated women, people living with HIV. Where are there community representatives in this panel or in the broader structure of your consortium? You have them, of course, in the CUBs, but are they also completely in part of the development, part of the outreach? How are they really involved in your study thoroughly?
Yeah, so thank you for your question. And it's a great point that you mentioned this. In our case, in the work package 6, we did involve the women, depending on which country it was, in the development of the awareness materials. And obviously, we had the input that they participated in the collaborative user boards to see what they would like to have or what they would not like to have. But it's true that it's been only that in those specific points, not as part of the research team. That's a good point that you raised.
Thank you. Yes, so perhaps for the future study that you were also describing, if you want to be it's to be participatory thoroughly, it would be really interesting to see how you can, this whole principle, of course, of nothing without us, about us. We're talking about people, but they're not really represented yet. Thank you.
Yeah. Yes. Also, what we saw in the CUPs was that if we could reach people who had previously been in vulnerable positions, ex-sex workers, for instance, they were local champions because they had the energy and the spirit to reach out to people who are still in vulnerable situations. So in that way, we were able to engage. They were the gatekeepers. They were the most important gatekeepers that we had. Those who are on the other side at the moment, and some of them had also become, nurses or clinicians afterwards, not as part of the CUPs, but they had the ability to be the best gatekeepers that we really had. So thank you for coming and taking on that.
And I'll just quickly add, thank you. It's a very fair point. And I know that with a lot of engagement, that it's a slow but building movement of having representatives with lived experience on panels such as this. What CBIG-SCREEN had really done well, I believe, is that there was a lot of flexibility and adaptation to working with people with lived experience to then build their advocacy skills. So, for example, Bulgaria was not an intervention country, but our co-creation focused on how can we provide a platform for their stories to be heard and have a legacy of that message, while maybe not present today, but have been presented at international conferences and available for access at any given time. But it's a work in progress for sure.
I'm just a bit cautious of time. I just saw that it's already 12, and I would love to continue this discussion. I hope we can continue this discussion maybe at the next meeting, next roundtable, where we focus more on the discussion of especially also those aspects. How can we bring everyone to the table? What can we build from that? And what do we have to keep in mind? Well, we still have HPV Faster Implement, which is still running a few more years. So there will be future possibilities to engage. I would like to say thank you, but Cynthia, I would also like to give you the last few words to the roundtable.
Well, first of all, Heidi, I would like to compliment you. You're an excellent chair, very understanding, I have to say, very pleasant, and just it was a wonderful meeting. I also am bowled over by the expertise, and it's very understated, quiet, sort of sensitive expertise on this panel. You're just amazing people. That's all I can say. Amazing, and I'm very much heartened by this meeting. I particularly want to thank Peggy Maguire yet again, because I think she might have been instrumental in involving me in this meeting. And I just want to say that the work that's going on is phenomenal, and I wish you the best and keep going. I'm not going to use your titles because I'm just going to call you like super experts. Everybody's a super expert. So whether you're a professor or an assistant professor or whatever you are, a doctorate, I just want to say thank you to Mark and also to Pia and also to Pranil